So welcome to this evening's talk on from GAP MASLD MASH Community Network, sponsored by Madrigal Pharmaceuticals. My name is Summer Collier. I'm a nurse practitioner in hepatology at UC San Diego Health. This is the QR code to record your attendance for the meeting. And today I'll be reviewing pharmacotherapy for metabolic dysfunction-associated steatotic liver disease, or MASLD, and we'll cover currently available treatment strategies, emerging therapies, and clinical considerations for managing patients with MASH and fibrosis. And so when treating MASLD, we focus on managing metabolic drivers, including obesity, type 2 diabetes, hypertension, and dyslipidemia. Lifestyle changes remain really the cornerstone of treatment, and this is through diet, physical activity, and weight loss recommendations. And as we know, 7 to 10% of weight loss can improve and reverse fibrosis associated with fatty liver. But as we all are aware, it's really hard for many patients to achieve that amount of weight loss and keep that weight loss off. And so really only a minority of patients are able to do that without additional support. And so for patients with more, and then in addition, for patients with more advanced disease or with specific histologic features or features on biopsy, we may consider more liver-directed treatment, which may include vitamin E, pioglitazone, or the newest agent, resmetirom. And so we'll get into more of those liver-directed treatments in the next few slides. And looking back a little bit on controlling some of those metabolic risk factors, we'll highlight here the GLP receptor agonists. And so GLP-1 receptor agonists, these are medications like semaglutide, tirzepatide, Ozempic, Wegovy, or other names for these medications, or Mounjaro. They have a dual benefit. They help to lower blood glucose, and they also promote weight loss. And then the way that these drugs work, they mimic a hormone released after eating that helps regulate insulin and slows gastric emptying. And so it signals to the brain satiety or fullness. And this helps, with weight loss, obviously. And so this makes this class of medication really ideal for patients that need to lose weight and patients who have type 2 diabetes along with their MASLD. And so the use of these weight loss therapies, which, really outside of medications can include other modalities like bariatric surgery, as well as the GLP-1 agonists, they really have been groundbreaking in providing a way to support our patients achieve the weight loss goals that are needed to improve their overall health, but also to improve their fatty liver and their MASLD. And so what is the role for GLPs in hepatology practice? Well, there's some emerging trials. In a recent trial, semaglutide showed promising results. It led to MASH resolution in nearly 29% of patients and improved fibrosis in over 14% of patients. And so GLP-1s should be considered for overweight patients with MASLD, particularly those with biopsy-confirmed MASH or fibrosis. Those are the patients you really want to target on getting them on medications earlier, and because we know weight loss can really improve MASH. And then we want to consider, for other modalities, if patients have a significant weight loss, if their BMI is very high, we may want to get them into a weight management specialty that may consider bariatric procedures as well to support weight loss. And then thinking about the wide use of GLPs now and how does that affect GI providers? Well, we know that these medications do delay gastric emptying. And so For patients who are preparing for a GI-based endoscopic procedure, so an endoscopy, and that are going to be going under anesthesia, we want to advise patients to hold their GLP ones for 1 week or 7 days prior to that procedure to reduce that risk of aspiration. And you may want to consider if you're, actively preparing the patient the day of a procedure to ask these questions and consider maybe delaying that endoscopy or colonoscopy if they took that GLP-1 injection within that 7 days. And so one of the medications that have been indicated for MASH in the past is vitamin E. And so vitamin E at a higher dose at 800 IUs a day has been indicated for non-diabetic MASH patients without cirrhosis. And this stems from the PIVENS trial, which was published in 2010. And it was a landmark study, and it showed that vitamin E improved liver histology or findings on biopsy in non-diabetic adults with NAFLD. Now we have a new terminology of MASLD, but we can that are interchangeable. And so you'll hear me say NAFLD sometimes when, or NASH, and that's interchangeable for MASLD and MASH. So with this trial, the effectiveness rate was shown to be around 43% that showed improvement. So that's pretty great, right? But there's several limitations with vitamin E. First, not all patients respond, and we have limitations for patients that are diabetic. It's not advised. For patients that have high blood pressure, especially uncontrolled high blood pressure, I would not advise to use vitamin E. It has potential risk of bleeding, potential risk of perhaps hemorrhage if you have uncontrolled high blood pressure. There's a potential link to prostate cancer. And so because of these concerns, there's some variance in guidelines as far as use of vitamin E. With the 2023 AASLD guidelines suggesting vitamin E may be considered in patients with MASH that are non-diabetic. However, the European guidelines do not recommend vitamin E for MASH due to its limited efficacy, as well as especially on fibrosis improvement and the limits in the potential risks that can occur. So you really want to be selective when thinking about vitamin E. I would say that patients should not be started on vitamin E unless you have a biopsy that's confirming MASH, and then also with consideration and a discussion with the patient about the risks. Pioglitazone is another medication that has indication for MASH, typically at a dose of 30 to 45 milligrams a day. This is for MASH patients with or without type 2 diabetes. The PIVENS trial actually did not show any benefit of pioglitazone over placebo for the primary outcome of improvement in histologic features of MASH, but in some of the secondary analysis and secondary outcomes, there was improvement in cardiovascular risk. There are some concerns as far as potential side effects or risks, risk of weight gain, which of course are patients that we're encouraging to lose weight. It's a hard sell to get them on a medication that may cause them to gain some weight, as well as a potential for increase in edema, increase in bone fractures, especially in women, and a possible association with an increase of risk of bladder cancer. So you really want to be careful about which patients you're starting on this medication, and then making sure that you're monitoring for some of these side effects and risks. So resmetirom is the newest player in this space or treatment for MASH. It was FDA approved in March 2024, so it's been around for over a year now, and it's for non-cirrhotic patients with moderate to advanced fibrosis, which is defined as stages F2 to F3 fibrosis. It's a thyroid hormone receptor beta agonist. It works by increasing liver-specific metabolism and reducing fat accumulation, and it has, without any effects on the thyroid. So it's selective for the liver. And this is a kind of a busy slide, but it's showing the physiological relationship between the thyroid and the liver. And so I'll try to walk you through a little bit about some of the action points of why resmetirom is helpful for MASH. And so the production of thyroid hormones, or TH, is regulated, of course, by the hypothalamic and pituitary activity that release thyroid stimulating hormone. And the thyroid hormones regulate many metabolic activities throughout the body in several systems, including the liver. The thyroid hormone receptor has two major isoforms: thyroid hormone receptor alpha, which is more predominant in the brain and the heart, and then thyroid hormone receptor in the thyroid, and thyroid hormone receptor beta, which is more predominant isoform in the liver. And the drug resmetirom is a thyroid hormone beta receptor agonist, selectively targets for the liver, and its key mechanism in treating MASH include several roles, but one being lipid metabolism. Resmetirom activates the THR-β in hepatocytes, upregulating the genes involved in fatty acid oxidation and lipid metabolism, and this helps to break down the excess fat in the liver. It also increases the expression of bile acid synthesis enzymes and promotes cholesterol conversion to bile acids and enhancing cholesterol efflux from the liver. In addition, resmetirom increases mitochondrial biogenesis and removal of unhealthy mitochondria, leading to increased capacity to metabolize free fatty acids, and this reduces liver fat, which then indirectly decreases inflammation associated with MASH, or metabolic dysfunction associated steatohepatitis, so that inflammation associated with MASH, and then has an anti-fibrotic action as well that may help reduce fibrosis by decreasing the activation of hepatic stellate cells, which are responsible for that collagen deposition in the liver. So several modes of action, but overall targeting both the fat accumulation in the liver and then also targeting that risk of fibrosis development or progression. And so the Maestro NASH trial, it's an ongoing phase 3 randomized controlled trial of resmetirom in NASH with liver fibrosis. And so this is the trial that was published. Dr. Harrison was the lead, and it was published back in 2024, and this is what led to the approval by the FDA. And so the FDA approved resmetirom under the accelerated approval pathway. This pathway allows approval of drugs that treat serious conditions and that address unmet needs. And so because we really had no other medications in this space and a big need for treatment for MASH, this was approved under that accelerated pathway. That approval is based on intermediate clinical endpoints, and that is why this trial is ongoing, and we're waiting for the 54-month study. So this is a ongoing study, and we'll be looking for that longer term data to get the full FDA approval at that time. And the Maestro NASH phase 3 trial enrolled 1,000 patients, all patients with biopsy-proven MASH and F1B to F3 fibrosis. And patients received either 80 milligram resmetirom, 100 milligram resmetirom, or placebo, and was looking at two endpoints at that 52-week mark. And so those two endpoints I'll get into in a slide in a minute. From a safety profile, the Maestro MASH trial really showed mainly GI-related side effects for this medication, specifically diarrhea, nausea, And the serious adverse events didn't seem to be really different across all three groups, the placebo group or the lower dose or the higher dose resmetirom groups. And so overall, a pretty safe profile as far as ease of management. And so these are the primary endpoints that this trial looked at. The Maestro MASH trial looked at both MASH resolution with no worsening of fibrosis, so improvement in that steatohepatitis, improvement in that fatty appearance on biopsy, but no worsening of this fibrosis. And then the other endpoint was also for fibrosis improvement by at least one stage with no worsening of the fatty liver activity score. And resmetirom significantly outperformed placebo in both key outcomes, the MASH resolution outcome, as well as the fibrosis improvement by at least one stage outcome. And so this was true for both the 80 milligram and 100 milligram doses. And these findings really were exciting because it really marked a major step forward in liver-directed treatment options for MASLD MASH with fibrosis. So some practical considerations for managing MASH with resmetirom. It's really key to find the ideal patient for treatment with resmetirom. This is only approved for adults, and so you're looking for adult patients that have steatosis. That's important. Patients that have no other cause of that steatosis or chronic liver disease. Patients that do not have cirrhosis. Yet patients that have moderate fibrosis, and so moderate to advanced fibrosis as defined as F2 to F3 fibrosis. And so you're needing to stage patients with MASH or MASLD, typically non-invasively anymore, sometimes by biopsy, but patients with F2 to F3 fibrosis that are adults that definitely have MASLD as the cause of liver disease would be good candidates for resmetirom. And this is all in conjunction with diet and exercise counseling. So we can't forget that component. The approval from the FDA was with conjunction of diet and exercise counseling. As with any new agent, we need to consider potential drug-to-drug interactions. Drugs, this slide, it was developed to look at drugs that are completely contraindicated with resmetirom. These are drugs that have a strong 2C8 or OATP1B13 inhibitors. These drugs will interact and should not be combined with resmetirom. Fortunately, we don't see these drugs very often in practice, but gemfibrozil or Lozid, you may see it's a maybe in practice sometimes, and the other ones are protease inhibitors in the kind of that mid group with ritonavir and the other darunavir. And so if you are in a practice that is treating HIV care, you may see some of these protease inhibitors that you'd want to avoid. In the middle column, these are medications you can use with the resmetirom, but you want to be considerate about perhaps reducing the dosing as resmetirom. And then on the left-hand side of your slide, you'll see a class of medications that resmetirom may actually increase the activity of those medications. So you would need to dose reduce medications like pioglitazone to a max dose of 15 milligrams a day, or Singulair or montelukast. So just some considerations when you're thinking about starting medications. You want to do a good meta review. And then what will probably come up the most in your practice is the statin use. And so there are some max statin doses that are recommended or allowed. And so, of course, these patients typically have a lot of cardiovascular risk. And so many of our patients that we're starting on resmetirom will also be on a statin. And so just knowing these cut points, maybe even having a cheat sheet on your desk so that you know kind of a quick look, many of the times we'll have to reduce the statins before starting resmetirom. And a few other practical considerations. The question is still out a little bit about what is the duration of treatment for resmetirom, and when and how are we best to monitor patients after starting. There's ongoing evaluations, of course, with this ongoing trial, Maestro MASH, so we will likely have a lot more we'll definitely have a lot more data coming out with the trial as it proceeds to that 54-month in mark. And then we'll likely, the recommendation really is to think about restaging fibrosis with non-invasive testing, like a FibroScan, like a PDFF, which is can be part of an MRI, or a CAP score with a FibroScan, or an ELF blood test. So thinking about how you maybe stage the fibrosis to begin with, and thinking about restaging maybe a year after starting resmetirom. But there is an expert panel or expert panels who are currently working on getting a little bit clearer guidance about when those cut points are as far as continuing or discontinuing resmetirom, and when should this frequency of repeat testing for non-invasive assessment of fibrosis, when should those be done? And then a few questions remain, as resmetirom is more and more adopted. Obviously, widespread use of any new medication really depends on insurance coverage. Lots of times insurance coverage depends on the frequency of prescribing as well. So we'll see how this plays out over the years to come. Sometimes resmetirom is not available in every pharmacy, so kind of knowing your local pharmacies, and if you need to go through a specialty pharmacy. The frequency, like I mentioned about staging and repeat non-invasive testing, this is in development. And then some need for duration of treatment. How is this a lifelong medication for patients? Do we reassess? And when do we think about coming off or discontinuing a treatment? And this is the first and this is the newest drug to be showing really good benefit for patients with MASH and moderate fibrosis, or a moderate to advanced fibrosis. But there are also multiple agents currently in clinical trial. We'll likely have a lot more medications available for our patients, which is very exciting in the months, years to come. And so more, stay tuned for more options in the future. And for anyone that's listening that would like a little deeper dive into MASLD MASH, or into fibrosis assessment, into disease state, I encourage you to check out the GAP MASLD MASH Community Network, and you'll find additional resources specifically about Rezdiffra, and Rezdiffra is the trade name for resmetirom. And so you can find that education through this QR code. And that's going to wrap up this talk on the MASLD pharmacotherapy. I'm happy to answer any questions or hear about your experiences with managing MASH in practice. Feel free to contact me through this community network. And I look forward to hearing from you. Thank you.